Hello, everyone. You are very welcome to this month's AWARE webinar. I'm just going to give about a minute for people to join us, for everyone to come in. For those of you who are just joining, we're just waiting another 30 seconds for people to join us today, and then we'll start. Just check. That's great. So we'll start. You're very welcome. And this month's webinar is Living Well with Bipolar Disorder. My name is Claire Hayes. I'm Clinical Director with AWARE, Consultant Clinical Psychologist. And I'm delighted to have on the panel today our clinical expert, Dr. Declan Lyons, Consultant Clinical Psychiatrist, and two people who are longstanding friends and supporters of AWARE, who both are experienced bipolar disorder and are proof of living well with it. And we're delighted to welcome them too. And that's Sinead Keating and Rick Rossiter. So for those of you who aren't familiar with AWARE, it is Ireland's national organisation to support people who have depression and bipolar disorder, and also family members who are impacted by that. We would invite you to have a look at AWARE's website. There are lots of resources. AWARE provides free courses to help support people. The structure of today's webinar, I'm going to invite the speakers to introduce themselves briefly for a few moments. And then Dr. Declan Lyons is going to take us through some of the key points for people to know in terms of living well with bipolar disorder. And then we're going to move to Sinead and to Rick, and they're going to share with us their experiences and how they continue to live well. We invited questions prior to this webinar, and so our question box is now closed. We've received many, many questions. We won't be able to get through them all, but there are certain themes, and we'll be looking at the themes and specific questions within those. Just to flag straight away, those of you who asked questions specifically on your own medication, we're not in a position to respond to those. So I hope you can understand that, and we encourage you to bring the questions to your GP or your psychiatrist, your mental health provider, and ask them the questions. They're in a much better position to answer. We also won't be able to take questions afterwards. So if you have questions following this discussion, again, we really invite you and encourage you to talk to your medical practitioner. So with that, I would like to invite Dr. Declan Lyons to give us a brief introduction.
Well, thank you very much for that, Claire. My name is Declan Lyons. I'm a consultant psychiatrist here at St. Patrick's Hospital, and I lecture part-time at Trinity College. And I have an interest, as I think any psychiatrist does, in managing this condition. So I'm delighted to be here today just to share a few insights and particularly talk about an initiative that AWARE has in terms of our bipolar program, which we're going to pilot later on this year. So I'll be touching on that as well. Thank you.
Great. Thank you very much, Declan. And I know ladies first, but actually, Rick, you're top of my screen. So I go to Sinead second the next time. So Rick, if you'd like to introduce yourself, please.
Hi, my name is Rick Rossiter. I've been an active mental health advocate for over 6 years. I'm an ambassador with AWARE and Sea Change. I also work with Refocus Group out of the College of Psychiatry for their trainees. And basically I've been living with the bipolar disorder now for over 35 years.
Great, thank you very much, Rick. And Sinead? Sinead, you're still on mute.
Thanks. Can you hear me now?
Can, loud and clear. Thank you very much.
So my name is Sinead Keating. I am also a mental health advocate. Like Rick said, I'm equally involved with Aware and Sea Change. I'm a new mum to 10-month-old twins, and hence why I have my mute on, because this is my second Zoom in a year. I'm quite behind people. But my experience with bipolar started when I was 11, so I'm living with it more than 20 years now. And so in that way, I'm really quite experienced. I've had my diagnosis since I was 21. But it's just such a pleasure to be here today. I really appreciate you inviting me to be on. It's such a great opportunity to talk about how to live well with bipolar.
Brilliant. And Sinead, we really appreciate you being here. And I know being the mom of 10-month-old twins will already inspire and give hope to so many people. So we look forward to hearing what you're going to say, and Rick as well. So Declan, I'd like to invite you to talk to us first, please, about your thoughts in terms of the challenges of living well with bipolar disorder.
Thank you very much, Claire. So I want to sort of address a question. How do we conceptualize, how do we conceive of bipolar mood disorder? I suppose we could see it in a number of ways. And we could see it as a severe and persistent mood disorder, sort of chameleon-like in its variation and presentation, different from person to person, perhaps something that may be dominant and pervasive, may define too much of a person's life, we might say. We might also see it as a confusing, scary challenge, a call to discover a balanced life, and someone has to navigate this journey and this challenge. We might see it as a creative journey where life choices, relationship, personal identity is not defined by the illness, and that it can be reined in, and that can be a little bit optimistic. And also we might say that, I suppose, we could be at risk of denying the seriousness of the condition, but we must have that hope ultimately that we will get to this place. Or we may see it as a harsh teacher calling us to pay diligent attention to our health, our routines, our lifestyle, and so on. So I think I would say that bipolar disorder is a little bit of all of those. I think we have to say it's a complex, challenging condition. It is a challenging diagnosis. We know that the illness may not appear fully formed the younger the person is. We know that people, 50% of symptoms may appear before the age of 20, but still the diagnosis may not be clear. It may get buried in other issues. Half of people may have issues around anxiety or excessive or harmful use of alcohol. The misdiagnosis is common, and we know that it can take up to 8 to 10 years to get an accurate diagnosis of a bipolar mood disorder. And many clinicians may be involved. People may have to journey between up to 4 different psychiatrists or clinicians or medical doctors in one American survey. And 60% of people may get misdiagnosed as having a unipolar depressive disorder. I suppose medication issues also have to be scrutinized, and I think we've got to be aware that endocrine disorders, for example, and under or overactive thyroid have to be outruled. So there are certain physical conditions that really compel the individual, I think, to present to a GP or to have a good, thorough physical examination, just to rule those out. So what are the different subtypes of the condition, and where do my symptoms fit on the spectrum of this illness? I suppose if we're saying types 1 and type 2, they're pretty unmistakable, particularly type 1, the classic form of bipolar mood disorder, where there are major highs and major lows. And mania, manic episodes, are really the diagnostic discriminator. And depression in bipolar type 2 is quite dominant. But there's also types 3, 4, and 5, at least, and people, researchers in this area, will subtype even more. Type 3, often to be found in females, where we have cyclothymia, and there are brief or less severe hypomanic episodes in depression, which don't reach a severity criterion to warrant any other subtype. And that has to be there for at least 2 years. And this can be quite an unpredictable, difficult condition to live with. Type 4, those of us in working in full-time mental health are aware of this condition, where people can experience the emergence of manic or hypomanic episodes after exposure to antidepressants. And there really is a call here for us diagnostically to get it right, so that this does happen very infrequently, if at all. And type 5 is essentially where the individual really has a family history of bipolar illness and very clear family history, but the person only themselves experiences depressive symptoms. So subjectively, people will be able to map some of their symptoms onto one particular subtype, and that's fair enough. But I think we have to be careful about coming up with a subjective diagnosis. The diagnosis does require objective verification, but certainly symptom awareness is really, really key. Upping our game in terms of diagnosis. So how do we get the correct diagnosis? How do we come up with the correct subtype? Because that is important, because treatment implications follow on from that. Family history is very important. Is there a history of a bipolar mood disorder in first-degree relatives or in other relatives? What about the course of the illness? Has it started under the age of 25? As I said, 50% of people, even by their 20th birthday, may have symptoms. Are there previous highs, previous episodes of elation or hypomania, lesser form of elation, that really people discount as being normal? And that can be a problem. How do we identify these to get the correct diagnosis? Often symptoms, as I say, can be hidden under substance misuse, which can be an exercise around self-medication, using substances, alcohol, very typically, to kind of calm people down, or for sleep purposes, for example. What is someone's response to previous treatments that they have had? Very often in bipolar illness, there'll be a suboptimal outcome with antidepressants, or we will see this hypomania, we will see this cycling starting. And that's important information. If we know that, I think that's a very, very big clue. But very often it's hard to stand back and realize that actually antidepressants may not be helping the individual, and the individual may feel that they're just going through repeated episodes, but in fact the antidepressant may be partly to blame. It may be part of the problem. So how do we get this information, this inventory of manic episodes or briefer episodes of mania, hypomania as we call it? And we can do it obviously in the subjective account, but sometimes questionnaires are actually quite helpful for that. And I think we need to probe as clinicians and educate our primary care colleagues and educate people to better describe their symptoms. So the superficial symptoms need to be probed quite in depth, I think we would say. Stigma and coming out as bipolar. So, you know, this is very difficult. When the illness arrives in one's doorstep, it is not a welcome visitor. And I think it's important to say that it's not your fault. This is a genuine condition that has multiple causes. It is not the result of an irresponsible lifestyle, nor is it your identity. It is a problem that can be managed and has to be managed. People should not feel judged for having this condition. You are, after all, in very good company. 1 in 5 of us will have mental illness at some point in our lives, and in 1 in 25 it can be a serious form of mental illness, such as bipolar. And there are misconceptions about bipolar, about the illness, that people with it can be accelerated, speeded up, irresponsible. And that can be very offensive, but it shouldn't mean that we don't ask for help, because really only a few people around us need truly understand. How can we, in the midst of that, look for people who will be supporters through thick and thin, the 2 a.m. person who we would call at 2 a.m. in the morning. I suppose being a positive role model for oneself is the main responsibility that people have in managing the condition. I won't say embracing too lightly, but you know what I mean, that people will take this condition seriously, they will take support and advice, and they will manage it very proactively. Being in the driving seat of management is, I think, the main responsibility we have in relation to this condition. So that's all I have for the moment, Claire.
That's great, Declan. Thank you very much. And I know you're going to come back to us. And what you've just said is a great introduction and lead in for Sinead and Rick, and two questions that we've got specifically around stigma. One person saying that the person has been diagnosed with bipolar disorder and is very deliberately not telling anybody else about it because of this sense of stigma. And another question asking of, are there benefits in being open about having it? So Sinead, I don't want to influence what you want to say, but I just think they're really important questions that we can address at some stage in this conversation. So if I can invite you, Sinead, to talk about your own, whatever you would like to say in terms of living well with bipolar disorder.
Well, just to give a little bit of background about how I came to a diagnosis. So I know I said briefly that I had my first experience when I was 11. And I'd been a very happy child, and I had a very sudden, I think over just a 2-week period, change, I suppose. I became very, very anxious, really worried about things that in hindsight didn't need worrying about, and were quite, I just want to say abstract, bizarre things like money, or that I would be left somewhere and forgotten about. And I had a panic attack. And that was my first episode. And I did go to see a clinical psychologist at the time. But looking back now, I think because I was a child, we ended up talking about symptoms rather than the core. And I don't know would it have been possible to talk about the core. But I just felt sad and particularly angry going through my teens. And I thought it was interesting what Declan had in the slide about how common a misdiagnosis is. I feel so fortunate that I didn't receive any other diagnosis. I got my diagnosis, which is bipolar type 2, with the first consultant psychiatrist that I saw, who I'm still with. And I think that has had quite a powerful impact on how I deal with it now. The slide also that Declan had about coming out with bipolar and learn to live with it, I'm obviously extremely open about it. And I talk about it in a way that's not particularly private, even when I do things like this, where I talk about it in public. And that's been a real learning curve. I would say that that's taken me the 12 years to where I am now, to find a way to talk about it in a way that's comfortable, because for me, the people around me have grown with me. I've been with my husband since I was 17, so he's been in that journey all along. And the things that were important, I think, for my diagnosis, because bipolar type 2 involves hypomania. So like Declan was saying, with bipolar type 1, it'll be the big highs, and I wasn't having that. In my teens, I was staying awake for 2 or 3 days at a time, and I thought that was great. I just stay up and write or listen to music or cry, which I thought was completely normal, because I didn't have any other frame of reference. And I think particularly the staying awake, not being able to sleep, really helped me understand that within bipolar type 2, it's very much in my head. Bipolar doesn't begin with feelings. It begins in my head, and my brain speeds up. I can't concentrate. Sleep is very difficult. I become really overwhelmed and intensely anxious. And it does just feel like the cog in my head is speeding along. I hope that's a helpful way of describing what bipolar type 2 is, because the feeling of it being in my head is what helps me recognize when I'm having an episode. Does that make sense?
It does, absolutely. That's very helpful, Sinead. Yes, yeah. So if you want to say more, do, or I'll come to Rick and come back to you. What seems right?
Just wondering, the benefits. Will I answer that question? The benefits of being open. I mean, for me, the benefits of being open about it are enormous, because it means that I have control about how bipolar sits in my life, and I can't emphasize how that is not a small thing. When I got my diagnosis, I very clearly remember the day. And I came out of that meeting with my psychiatrist, and I was in the Student Union Centre in UCD, which is fortunately where I saw him, and it was free, and that was amazing. And I sat down and I had a really good think for about an hour, And I recognized equally what a weight it was off my shoulders. And it was so important what Declan said. It really isn't your fault. For me, that's a massive struggle. It's still a struggle every day. I apologize a lot to my husband when I'm not well, which I recognize is not, it's not relevant at all to be sorry, because it's not my fault. I recognized what a relief it was to say to myself, this is not my fault. It's not something that's wrong with me. This is something that other people have. And I can kind of put it in a box and leave it over here, that it's not me, it's something that's happening to me. I equally was aware that this was very serious, a diagnosis. It would be with me for the rest of my life. And I was, even though I couldn't anticipate the type of stigma, which is actually a word I don't really use in my own life, I just use the word shame because that's what it is to me. I knew I didn't know what the shame would be like, and I couldn't preempt the events that I would have with other people. But I knew that shame would exist, and I thought, I don't want to shame myself, so I want to live with this as if it's as common as a cold, but as serious as cancer. Now, that's not, I'm not trying to draw a parallel with cancer at all. That's just what I thought when I was 21, that I'd gotten this really, really serious diagnosis. And I wanted to deal with it like that, because it was going to have a huge impact on my life. It already had a huge impact on my life. And really it stopped me functioning. I was 2 months into a master's, and that kind of all went out the window. But I have control. I talk about it now in a way that's comfortable for me. And what's happened is the people in my life now, years later, are people who are comfortable with that and who are supportive with that. And I think that's actually my main takeaway from how to live well with bipolar. You have to, it's so important to focus on how you want to deal with it, what you are comfortable with, separate from everybody else. And that's really tricky. And I think it's really important to have the support of a therapist with that. But it's so important. You're the person who has to live with this. I'm the person who has to live with this 24/7. I'm in my head. So it's massively important that I do it how I want. And that's non-negotiable. And I hope that if there's anybody watching who's experiencing bipolar and finds that hard, I find it hard too. But it's so important.
Sinead, just before I move to Rick, I'd just like to ask you one question, if I may. When you say shame, it's a really powerful word. And I know Brené Brown is someone who talks a lot about shame, and her podcasts and TED lectures are really, might be a good resource for people to look at. But are you talking about shame in terms of being shamed by other people's ignorance, for want of a better word, or fear or lack of understanding? Or is it the shame you were experiencing yourself, internal shame, or is it a bit of both?
Oh, it's both. So it's funny you should say Brené. I just have up Brené's parenting manifesto on my wall. I can't tell you how much Brené's work has empowered my life. I highly recommend anybody who hasn't seen Brené's work to go and look at it, look at her TED Talks. Shame is something that lives within me, and it's something that's placed on me by other people. And the reason I tend not to use the word stigma is because when I talk to people who haven't had an experience of mental illness themselves, often there's a difficulty in understanding what stigma is. And I often think that's because it's not a feeling word. And so I don't think it translates very well between a person who experiences stigma, self-stigma, or stigma from other people, to people who maybe don't experience that in the same way. And to me, feeling stigmatized is feeling shame. It's either feeling internal shame or it's feeling shamed by other people. And the root of stigma, if you like, for me, is that at some point or other, the vast majority of people don't believe that I'm sick. That is what happens. And that can be a subtle comment. I've had things like, you know, it's really unreliable or unprofessional to call in sick to work. I've been told that I'm not being helpful. I just don't want to be helpful to people when I'm sick. I've been told that I can't access a certain support because the job of the health professionals in that support isn't hand-holding or soothing. And they are all shaming in the sense that we don't really believe that you're that sick. And that is very, very powerful. And stigma or shame really, for me, goes on a scale from subtle to most obvious. Most obvious being mental illness doesn't exist, which is really obvious to flag. It's easy to flag for me at a distance. Somebody says that, I'm like, right, see you later. But certainly in my close circle, to get that comment of you're just not being helpful, you don't want to be helpful. When I was sick and very open about being sick, that's somebody saying we don't believe you. And I have to believe myself. So I have to have a boundary there.
And that highlights for me another word that you said that I like to pick up: compassion. And we don't have control over people giving us compassion, but we certainly can work on self-compassion. And I know that's really, really important. Sinead, I am inspired by you, and thank you. And I know what you're saying will help so many people already. So Rick, I'd like to move to you then, if that's okay.
That's fine.
You can take the conversation whatever way you think would be helpful.
Well, probably from the beginning, it's similar to what Sinead was going through. It started at a very early age for myself, and it wasn't, something that would be discovered right away. As they said, it can take a very long time to get the diagnosis. I was 12 years old when I first started seeing a psychologist. Behavior in school, behavior at home. My parents couldn't understand what was going on, so they decided to go that route. Basically, they put it down to my adoption. I was adopted at 6 months old, so they put down my behavior as a rebellion against it. There was no really look or insight into mental health in that frame of mind. And then around 15 years old, I started having suicidal thoughts. Well, 13, I had my first suicidal thought. It was just something that came over to me in home economics class that I just really wanted to die. And then probably around 15, sort of plans started forming in my head over this thing. And I had a lot of stress going on with the family. I couldn't really go to anybody. The 2 or 3 key people that were in my life that I could go to were no longer there for one reason or another. So I was just sort of left on my own in a sense, even though I did mention it to my mother once over a phone call that I felt suicidal. And that was the last I heard of that conversation. So when I was 15, I attempted the first suicide attempt, and the repercussions were very severe. I damaged my body in a great deal. I was hospitalized physically for 3 months, and even to this day, I'm still dealing with the repercussions of that incident. But after that first suicide attempt, it took them close to 3 or 4 months to get me into a psychiatry unit to check out how I was doing, that way. And it was an adult ward, so I was, nowhere near my peers. I was thrown in with adults that were anywhere between 20 to 45, 50. So I was out of my element. For 3 months that I was in the hospital, I still don't know what they thought. My parents wouldn't even be able to tell me what was being considered or talked about. It was like I was in the hospital for 3 months and then just gone. And, it never even really occurred to me that I had a mental health problem, because it was almost like nobody really talked about it as if I did. It was almost as if it was my attitude or something that I was doing, externally. Even though like I was going through these emotions, to me, it was like, it was natural what I was doing. Whether it was being hyper or being depressed, this is how everything is. It was all normality for me. As the years went on, I just felt like no matter how many times I either tried to, attempt suicide or I seeked help or anything, go in and out of A&E, I was never hospitalized again. So for me, it was like nobody really considers this a big thing, so I gotta hide it, throw on a big mask. And are we getting feedback?
Yeah, no, I'm listening. Well, I'm listening. I presume everybody else is as well.
No, I'm just hearing your feedback on myself.
Yeah, are you hearing feedback? Do you want to keep going, Rick?
Yeah,
or do you want...
no, I'm fine.
Okay, thank you.
So yeah, it was just something that I found that I had to hide because nobody was taking it serious for me. You know, my family didn't want to talk about it. Like when I had that first suicide attempt at 15, it was in September. And the following year, I went back to school in January. And that was the first time somebody asked me why I did it. It was all just, you know, hid under and shoved under the carpet. So I just basically learned how to just hide it, not talk about it, not deal with it, even though my mind was like in a whirlwind. Medication was never brought up about anything. So I just basically went on with my life and tried my best. And then it wasn't until I came to Ireland when I was 26 years old, probably about 3 months after that, I had a major episode and I was hospitalized for 2 months. And that was the first time anybody ever told me that I had it. At that time, it was called, they said it was manic depression. And, you know, the worst thing is once I was told the name, that was it. I wasn't getting any information on it. No training, no understanding of what it was, what it meant to be. I never even heard the word trigger until a few years ago. So it was like I was left on my own to educate myself after a while, but it took a long time to do that. So many ins and out of hospitals, so much saying like I am bipolar. It was my identity at one point. It's not like you would say, like Sinead would say, like cancer. Like my sister wouldn't say I am cancer. You say I have it. But you know, for me, for a lot of people, like I'm schizophrenic, I'm bipolar, I'm, you know, it becomes a part of my identity. And it took a very long time for me to take ownership of what it was and to turn it around on its head, mainly out of stubbornness, because I was told by a psychiatrist at one point that I would die by my own hands. No ends about it. So that's almost like a challenge now to me that I'm not going to do that. And I'm going to survive no matter what I go through in life. But yeah, it was a very bumpy road. And as you would say, with somebody talk about coming out about it, opening up, like I was very open at 16, talking about it with friends and family. I didn't hide from it. But over the years, I started to, because over the years, I got into circles, whether it was work or colleagues and stuff. And, you know, if I did mention it, maybe that colleague wouldn't be around me as much, or I would stop seeing them on a personal basis outside of work. People would just drift away from my life. So again, that's when the mask started coming up, and I just wouldn't really talk about it to nobody. And it took a very long time. And I remember when I was in a hospital in Tralee, I was just crying at a psychiatrist, and I just said, I am so tired of all these faces that I'm wearing for other people. I was just so sick of it, and I needed to get rid of them. And I needed to just come out and say who I was and be who I was. But that journey took a long time. And it's only been the last 10 years of my life. I just turned 50. And it's only really been the last 10 years of my life that I've been the best I could be mentally. And, you know, it was a hard time. My last suicide attempt was in 2007. And, you know, it took almost like an enlightening moment, an epiphany to really come out of that mode and, you know, to drift away from these concepts of self-harm and suicide. And right now, just like Sinead, I'm telling my story, and I just hope it will help other people. And I can honestly say recovery is possible, but it's not like a recovery from a broken arm or anything like that. My recovery is continuous. It's going to be on every day of my life. It means me being prepared, me being, you know, understanding of my circumstances, support, understanding, knowledge, everything. So it's not just going to be one thing in my life. It's not just going to be medication. It's not just going to be therapy. It's It's always going to be a combination of a lot of things put together to keep you going. The new Zoom. She's on mute.
Yeah, I was muted because I think my not being muted I think was causing you feedback. So apologies on that. So I had to put on the glasses to mute or not. Rick, I cannot thank you enough in terms of the support, the work you do, not just for Aware and not just for Shine, but for everybody in terms of being open about your own experiences. And when I work with young people and they talk about feeling suicidal, I'm really clear that in my view, there's no such thing as feeling suicidal. They're thoughts. So people think they're better off dead. They think the world would be better off without them. They think they're doing their families a favor. And you're a great example of how we have options and people do not have to harm themselves. They do not have to take their own lives, irrespective of how bad they feel. So I just really want to thank you for that. And just as I know Sinead is giving people hope in the sense of being a mother with twins who has experiences and continues to experience bipolar disorder, your openness and frankness, Rick, in talking about your experiences where at times in your life, things were so difficult, you genuinely at those times thought you were better off dead, but you chose not to take your own life. And as a result, you're here inspiring me and giving hope. So we'll come back to you with more of the questions, but I really want to thank you for that. So Declan, if I can come to you then, and I know you have other points that you'd like to make in terms of supporting people and family members indeed to support people to keep well with bipolar disorder.
Well, I think I have a few slides, I think, again, Claire. So just to say while they're coming up, my gosh, I know Rick and Sinead, but I just want to pay tribute to them. I see scars, but I see strength, and I see survival, and huge admiration and respect for that, very much so. So getting intimate with the medications, we've heard that one of the treatment interventions for bipolar illness is medication. And I think there is a really important imperative to know the rules, the monitoring that goes with medication and the purpose of medications, to kind of get to know them intimately, to embrace them as one tool, not the only tool, but one tool that can certainly be play a very helpful role in terms of achieving stability. Now, there are obviously side effects of medication, there are benefits, and just to note those for people to kind of be aware of medication. What are the positives and the negatives, the downsides, particularly if exposed to antidepressants, as we've said before. Antidepressants can be helpful for a brief period, and many people with bipolar illness are taking them, backed up by mood stabilizers, but it's helpful just to know, are they having a beneficial effect? Are they agitating, or is there an excitation or whatever? Medications ideally should be, the ideal drug should be effective, tolerable, and safe in the longer term. We've got to think longer term with this condition. Immediate efficacy isn't enough. We've got to think about, because the condition very often is enduring and ongoing, medications can certainly quell symptoms, but what about their tolerability in the longer term? I would encourage people to be patient with us, the prescribers, themselves. Sometimes numerous medication trials and even combinations of medications may be necessary, and it may take some time, some months or longer. So the golden rule, I suppose, meds aren't perfect, but they can make the illness manageable. And if things are working, if things are stabilizing demonstrably better, it's a good idea maybe to persist with what is working. The need for therapy, I think we would say that obviously medication and therapy and education are the cornerstones of treatment. Those three prongs, medication, education, and individual therapy, is very important. To the therapeutic aspects, to kind of come to a formulation, to accept the diagnosis, to actively participate in treatment, also to get into the monitoring of mood, that can be very, very helpful to give you and to give your clinician, your therapist, your psychiatrist an overview of the condition, of whether it's stabilizing, what are the stressors, what are the factors that need to be looked at. In terms of thought restructuring, we all get distortions in our thinking. We all need the skill of balanced thinking. We all need to catch and challenge and change unhelpful thoughts. This is a universal life skill. We all need to problem solve, and sometimes with the condition, with the reaction of other people, with the limitations sometimes that it imposes on us, we have to problem solve and work around it. We all need to enhance our social skills and keep our social self-esteem at a high level. But above all, we need to stabilize our routine around sleep, around social interaction, around chores, around daily life skills, self-maintenance, and so on. That sense of stability is really crucial in getting a good outcome. So you can see why Aware has had to come up with this bipolar program, which we've talked about, and the huge educational gap and understanding gap that is out there. I think we've heard from Sinead and Rick, that's personal, you know, when people are having to try and explain the condition and to make sense of it for themselves, and more importantly, because there are the avenues of help. So this 6-week program for those experiencing bipolar illness will hopefully be informative and educational, with an invitation to family members or a supporter to participate at the end of the program. What we want to cover, the broad themes, are the facts of the illness, the causes and course of the illness, as much as we can say about cause, effective management principles, and in terms of education and lifestyle adjustments that, if made, can ensure the best outcome. What complications and disruptions are there, and how do we get to a place of embracing acceptance? Acceptance is a lovely word that really means a calmness, a stillness, an embracing reality, and the opposite, in a way, I suppose, of what the worst of bipolar wants to propel us towards. Now, in terms of the teaching methods, this program has been, the first version has been made. It's being hopefully taken apart and restructured and polished, and it will be a blended learning approach, we hope, with some didactic material, plenty of discussion, maybe even, you know, this virtual platform that we've all had to adapt to will be deployed here for all sorts of efficiency reasons. And we hope to get to a place of piloting it in late 2021. So keep your ears peeled. We will keep you up to date about that. I suppose the cry is sometimes making sense of what can be sometimes insensible and having to do it on one's own. I can't do this on my own, and no, you can't. So what supports do you need, and what supports can do for you? I think by encouraging, by learning coping skills and sharing concerns, people who have the condition really know the tricks very, very well, and can be role models and inspiring for others that have the condition. And that can literally help save a life, as you know. It can help people accept the diagnosis. That's what peer support can be about, to come to a place of acceptance, above all to reduce isolation associated with the illness. And this has been, you know, challenging during COVID times for a lot of people, not just people experiencing bipolar illness. Family and friends can also build understanding and learn a supportive stance, and learn to say the better thing, to not to be dismissive, not to be even mindlessly, not with any great ill intent, but just to be automatically more supportive. So support network can be a great forum for education, to learn about symptoms and trigger, and above all, crisis response. And sometimes that can be quite predictable. And sometimes people do go through various episodes, and there are obvious patterns that stand out, but really hearing about that, and then the penny can drop. This is personal, this is me, I can manage this by changing my stance. I want to finish then, last slide, with Sinead Mertz. And I'm sure you've seen this, and I love this piece by Ellen Forney. She's a creative artist in Seattle. I think she's based in the Pacific Northwest of the US. And she came up with this mnemonic, a take-home wellness mnemonic. You've probably heard it. But sleep is the essence of, I think, well-being in bipolar disorder. Can I share some insights around sleep? And you probably know, from those of you that are looking at research forums and blogs, that tart cherries can be helpful as a natural sleep remedy, and kiwi fruit from Professor Jason Ellis in London. He believes 2 kiwi fruit a night really can be quite a powerful antioxidant, as well as a melatonin enhancing effect. Medications, get to know your meds. They are a very, very central tool for some people. Some people, a minority of people, can just really play by the medication rule and really sometimes ignore the condition. Other people have to put a lot more effort in, and the majority of people do. Pay attention to your diet, what you're eating, eat healthily, eat a balanced diet. Engage with your doctor and your therapist, whoever it may be. Really work on that good supportive interaction with a number of key people. It can be your pharmacist, it can be the receptionist in your GP surgery, your therapist secretary. These are the professionals that you need to work with. Be mindful. Learning to calm and still the mind can be a great skill to step back from the topsy-turvy of the condition. Exercise, we know this beyond any need to research it, that spending time in nature, physical exercise is really, really helpful, natural coping mechanism. And routine, stabilizing one's routines is a very, very useful stance to take in terms of living well with the condition. And tools for coping that you can pick up in therapy, pick up from peers, and the peer network, a support system that is solid, that you support yourself, that you proactively reach out. It can be very often culturally acceptable, I think, in this country to kind of muscle on with and not reach out for help. And it's a self-defeating stance to take. You know, we do need to disclose, to admit that we're vulnerable, that we can support each other. And by you reaching out to people, you will be able to support them in turn. People feel really valued when they're turned to, not only in a time of crisis sometimes, but along the way as well. So that's MedMerts by Ellen Forney I wanted to share with you to conclude. Thanks, Claire.
Declan, thank you very much. You're not concluding just yet, though, because
indeed, no.
We have some questions, so I'm going to follow up with you first, and then I'm going to ask Sinead a question, and then going to go to Rick. So, Declan, we've got lots of questions around medication, and you've addressed those, and I know you saw the questions as you were preparing, as did Sinead and Rick. So some of the answers have been incorporated already. But we've got a particular question: can and does someone's diagnosis of bipolar change? And there's also a question in terms of, you know, can somebody have a depressive mood half a day and then go into hypo or mania for the rest of the day? And then the last piece is hypersexuality, that is listed as a symptom of bipolar disorder, but is never really discussed. So just to ask you those questions, please.
So the first bit around changing diagnosis, can it change? Absolutely. We are notorious in psychiatry for changing our mind. That can be frustrating, but also helpful, and that minds should not be fixed. We should have an open mind to follow people up, hear about their course, their clinical course. And sometimes diagnoses do change from even one category of diagnosis. For example, some people with bipolar illness may be diagnosed with the psychotic illness, with schizoaffective disorder, schizophrenia, but more typically around unipolar depression. And it's only with time, as a result of exposure and experience, exposure to an experience that people have with medication, for example, that really reveals the true nature of the bipolarity and that subtype of their mood disorder. So yes, that is common, that sometimes diagnosis is not fixed. It's based on the information that we find, that we're presented with, that the person experiences. And we are information seekers, and we are Sherlock Holmes, and sometimes there can be a different crime scene, to use that awful metaphor, and we have to make sense of it and interpret an episode, or indeed a bigger diagnostic category in light of that. The second bit, Claire, sorry.
That can someone have an experience of depression in the morning and mania in the afternoon?
Absolutely. I mean, typically, you know, major depression, for example, can be the day of two halves. Sometimes the day can start off and people can talk about this cloud lifting, and also bipolar depression, bearing in mind that in bipolar mood disorder, particularly as the illness goes on, depression is the biggest burden over time. So people can see that. And also there is another circumstance with more rapid cycling, or what's called more ultra rapid cycling, where there can be significant changes of mood, even within the same day, even within some hours. But I got a flavor of diurnal mood variation when you put that question to me. So very often people going through depression, we'll talk about the day of two halves, and the morning being particularly challenging where people are unmotivated, lethargic and low, and that lifts by the afternoon, and there can be a great sense of relief and function. People can function in the afternoon. And the last question was about hypersexuality. Yes.
As we keep hearing with the news people, briefly, please, the hypersexuality.
Okay. Briefly, well, yeah, we are too brief about this, to be honest. It is the symptom that people are embarrassed to report, and I suspect that clinicians are too embarrassed to inquire about. And it can be very destructive for people who are in a stable relationship, and people obviously experience this as a symptom. It may be a total variance with people's circumstances, with the security of a loving, enduring relationship, and then this happens. So we do need to explore it a bit more. We need to explore triggers. We need to see it as a symptom. We need to have contingencies, and people need to have a pre-planned response. Maybe some distraction techniques around physical exercise, and so on, and be open and discuss it with your partner because it can destroy relationships, hypersexuality. So maybe couples therapy may need to be embarked upon. So honesty, I think, being honest with oneself, being honest with your treating doctor, because physical health is at stake here as well.
Great. Declan, we've so many other questions. One about research, and is there research being done? And I know there is, and I'd encourage people to look at the AWARE website and to look at other websites as well and discover that. This is a conversation to be continued, and just on my own behalf, as well as AWARE, I'd like to thank you for the work that you've put into developing the first stage of what is going to be a really excellent program to support people with bipolar disorder. And I've been reading what you've presented, and it's just phenomenal. So thank you. And also for your time today. And
you're welcome, Claire.
Sinead, if I can come to you next, there's a question here from someone and saying, I live with a good friend with bipolar disorder. What kind of meaningful support can I give without interfering? Is there anything I should watch out for on my friend's behalf? And I know someone who I knew very, very well in respect with bipolar disorder talked about her frustration with spotters, that if she was in any way in grade form, they would come in immediately and say, oh, are you going high? But if she was experiencing, if she was feeling fed up, they never came to say, are you feeling okay? So what would your suggestion be? What would your response be, please, to that?
I mean, first of all, to say to that person, that's such a wonderful thing to be in the space where you're saying, how can I be supportive? Like, that's nearly half the battle, and that's amazing. So well done. And I don't say that lightly. That is so meaningful that you're even in the space to want to do that. I think that it's very important to remember that people with bipolar are also autonomous people who have choices, and not everybody will have the same choices or will enjoy the same type of support, if that makes sense. Enjoy is probably the wrong word, but appreciate or it will be as meaningful to them. So in that sense, I can't answer for somebody else. But what I would say is, when your friend is maybe having a good day, to sit down with them and to say, I really want to be as supportive as I can. Can you tell me what you would find helpful for me to do? And to have that chat with them when they're doing well. And if even if you haven't had that conversation, you're concerned, just to go and say, I want to check in with you. How are you feeling? Or if you're concerned, for somebody to say, I'm concerned for you. Does that sit with you? And so not to make a presumption, but just to check in. And that's such a lovely thing. As a supporter, you don't have to get everything right. That's not your role. And I hope that that's something that the person who asked that question, I hope that you can hear that that's not something to feel pressured with. You don't have information automatically about how somebody is feeling and how somebody is doing and what's helpful for them. And so to ask is the best thing when they're maybe having a good day. And if you want to say, can we make a little plan? How do you feel when you're maybe a bit hypermanic? How do you feel when you're low? And in those instances, what can I do for you? But it's such a wonderful thing to even want to ask that question. And that's so amazing.
Sinead, thank you. And I'm really struck by how you describe it as someone who has bipolar disorder, and Rick referred to that as well. The importance of language, that you're not labeling yourselves or anyone else as being bipolar. Yeah. I think we really need to listen very carefully to how you were speaking about the illness and how Rick is as well, and how you're managing it. Thank you very much. And Rick, if I can come to you, the last question. There are quite a few questions about bipolar disorder when someone is experiencing it and they have something else, like they have obsessive compulsive disorder, or is it linked with anxiety? What would you say to that? And I'm asking you rather than Declan, so it's not a technical question, it's more your own sense.
Well, coincidentally, it was pretty much 10 years after I was diagnosed with bipolar. I had an added diagnosis of borderline personality disorder. They almost coexist in certain different realms within me, and was so hard to figure out, because before I even knew any of these titles, any of these, as some people would say, labels and all that, but until I knew the name of what I did have, I couldn't understand how I could deal with it. So because of having the borderline as well, it was like when I thought the medication for bipolar was meant to be working, there were still episodes happening within my life. There were still things that were offsetting, and I couldn't fit one with the other. So knowing the two differences, I can pretty much look back in my life and say, that's when this was happening and that's when that was happening. So yeah, apart from, you know, having bipolar, there's going to be so many things that are happening in your life. And like Sinead would say, like for the people, if I was having a really, really, really good day, it would be like, are you going on a high? Or, and even with depression, it was like, are you having a very bad low? It's like, I can have a normal good day. I can have a normal, you know, bad day like anyone else. It's just thankfully that like the people in my life now, the supporters that I have, can figure out, can look at me and say, they can understand when things are going a bit off the rails that way, or things are accelerating. But when it comes to, you know, having a lot of different things going in your life, I've never met the same person with bipolar. We're all individuals. You can have substance abuse problems, you can have alcoholism. Like there's so many things that are being within your life apart from your disorder. Like it only makes up one small part of you. There's so many adages. It could be anything from race to sexuality, so many other things that are being weighed upon yourself and your disorder. So many other baggage that you're being having to carry with you as just a normal part of life, but that also ties into your mental health. So, you know, it's almost like a joke, almost saying like, you know, a person walks into the bar, somebody bipolar, somebody, you know, black, you know, all that thing could be one person. That one person can have so many different labels. They can have, you know, the race, the sexuality, the mental health, all these combinations that are going to be in one person. And it's almost monumental to think of somebody being able to deal with any of these things on their own, but to combine all these things in life, you know, I just hats off to anybody who can really survive these type of things. And it's just, I just thank God in this day and age where I see so much awareness with mental health, so much understanding, so much information at the fingertips. Groups like Aware and CJ, like all these different people, volunteers. It's almost beautiful to see that so many people can have such great support in so many ways of looking and seeking out help. It is truly wonderful to see that, but by no means are we there yet. In this area, we got so much to jump forward to and fight for.
And Rick, that's a really powerful way for us to bring this to a close. So much done, but we're not there yet. So in terms of language, in terms of change. And what's really struck me about working with yourself this morning, Rick and Sinead, is you have taken help. Dr. Declan Lyons, myself, other people give help as best we can, but it's up to each of us as individuals to take help, to take support. So for those of you who have been following the webinar, thank you. And this was being recorded. It will be on our website. We encourage you, if you'd like to watch back, or if there are people that you know who might like to follow up on it. And we'd like to just let you know about our next webinar, which is in April. My goodness, we're into April already. It's scary. Wednesday, the 14th of April, 2021 at 12 noon. And our theme is exploring grief and depression. So we very much invite you to attend there. You can sign up for our webinar. And also we really encourage you to look at the Aware website. I'd very much like to thank our participants today, our contributors, our experts, 3 experts, Dr. Declan Lyons, Sinead Keating, and Rick Rossiter. Thank you very much, Gomila Mahagav Galer. Thank you.
Thank you.
Thank you.